Good evening, ladies and gentlemen, dear students. We welcome you all to the next edition of the case presentations in nephrology, which is a unique academic initiative by the Indian Society of Nephrology. At the outset, we would express our heartfelt condolence and grief and great solidarity with the families of all those affected with the shocking disaster at Ahmedabad, and uh, and we pray to Almighty and hope that such an event never happens. So we think that the academic program should go on. So that's why we wanted to continue with the academic program. So for all the people who are joining us for the first time, we started this initiative just as an academic endeavor to again re-emphasize on the basic bedside clinical medicine, and we took an online format just to make our outreach to the maximum number of people. And and in the present era of investigations and lot of advanced things, the basic general examination, system examination, and history taking, just to highlight those things. So we have had about 7 or 8 sessions so far, and for those who could not attend due to various reasons, all the videos of the recorded sessions are available on ISN's YouTube channel. And we request you all to just register for the event so that we can send you the recorded videos, the important questions discussed, and other study material. We also request or make an appeal for more and more volunteer students to come forward and present. Trust me, all those who were presented so far have been quite thankful and have actually liked the experience of presenting in front of such great faculty. So our today's case would be an interesting case of anasarca, and followed by a question and answer and discussion. So our moderator and teacher for today's session is Professor Vivekanand Jha, and I feel deeply humbled to be introducing a person of his stature. And he actually needs no introduction all over the world. And Sir has numerous qualifications and achievements to his credit. He is presently working as the Executive Director of the George Institute for Global Health India and the Professor and Chair of Global Kidney Health. We all know him as the dynamic president of the International Society of Nephrology, especially during the difficult period of COVID. And for seniors like me, we have also seen him as Professor of Nephrology from TGI. And all those who follow IJN, and most of us know him as the editor-in-chief of the Indian Journal of Nephrology. When we speak of such awards, I think every possible oration, I think Sir has delivered, and he has got numerous awards and prizes in research awards to his credit. And when I speak of research, Sir, I think is a role model for all of us. And if not the topmost, I would certainly say that he is one of the top three researchers of the country. And he had multiple research projects to his credit, more than 30 extramural projects. And in many of the landmark trials in nephrology, which we all read and which have been a part of our clinical guidelines and active practice now, Sir has been the principal investigator and a key contributor. And speaking of publications, simply saying that he has a H index of more than 100 and more than 600, this must be an old figure, more than 600 publications in itself. But apart from these, I would just say a few things that Sir has been a transformative force in the global nephrology research. And he has led the whole world and defined research in nephrology, especially in areas such as epidemiology, which is generally neglected. And he has been a very strong proponent of innovations and evidence generation in nephrology. I have been fortunate to have attended some of his talks on this topic, and trust me, they're actually quite motivating and inspire you to do well. And he has been an active policymaker and a contributor to the various policies and various scientific innovations and methodological contributions to his credit. And he has not only led India, led the whole world, I mean the whole nephrology community of the whole world into this field. And for us, we have attended Sir's clinic earlier, And trust me, he's a teacher par excellence, not only for nephrologists, also for physicians. And he's not only a great teacher in nephrology. We have attended his research classes, that how to do research and various aspects. Even they are as good as that. And above all, we all look forward to him and see him as the epitome of success in nephrology. And he is an inspiration and a role model for all of us. So thank you for agreeing to teach our students. I am very sure all our students will benefit. We have Dr. Jugal Mehta, who will be presenting today's class. He is a senior resident from Mumbai. And you all know how to participate. Just keep yourself muted to avoid any disturbance. Any questions, please put in the chat box. When sir will be discussing and some questions are asked, all those who know the answers, I would request them to please put in the chat box so that you also have a practice of answering. And at the end of the session, if you have some doubts, you can point out the questions and do send us your feedback, suggestions, and comments. We have created a small WhatsApp group just to keep you apprised of the various updates. Most of you have joined. Any more, if they want, they can join. And without wasting much time, I'll stop sharing my screen. I'll ask Jugal to share his screen. And I would request, sir, please continue to this session. Jugal, you can share your screen.
Yes, sir. Is it visible?
Yeah, you're visible full screen mode. Yeah.
Good evening, everyone. I'll be presenting a case of a 43-year-old female resident of Mumbai who's an advocate by profession who presented with chief complaints of generalized weakness, bilateral pedal edema, and frothy urine since 5 to 6 weeks. I would like to date back my history 3 years back when patient was apparently asymptomatic when she noticed bilateral pedal edema, which was insidious in onset, gradually increasing and extended up to ankles. It wasn't associated with pain, tenderness, redness, or temperature, and frothing in urine, for which she consulted a physician who advised her to do a few blood and urine investigations. The investigation showed protein and RBCs in the urine, and she was told that her creatinine was 1.4. She was then advised to consult a nephrologist, who then advised her to do a 24-hour urine protein test and was told that she is losing around 7 grams of protein in a day, for which she was advised a renal biopsy. She had no history of decreased urine output, hematuria, nocturia, chest pain, palpitations, breathlessness, cough, orthopnea, PND, no history of jaundice, abdominal distension, no history of fever, sore throat, skin rash, photosensitivity, oral ulcers, hair loss, joint pain, joint stiffness, burning micturition, recurrent upper respiratory tract infections, sinusitis, hemoptysis, thrombotic episodes, weight loss, decreased appetite, any use of NSAIDs, or any use of alternative forms of medicines or cosmetic creams. The renal biopsy was then performed, and there was no history of any post-procedural complications. Now, following the renal biopsy, she was started on steroids, but after 3 to 4 days of consumption, she complained of severe dyspepsia and weight gain, due to which she stopped taking the steroids. She then consulted another nephrologist, who then started her on telmisartan 40 milligrams and prednisolone, which was then gradually tapered over 6 months and then stopped. During
Can
this,
I,
yes,
Dr.
sir.
Mehta, thank you. Can I stop you here
Yes,
and
sir.
ask you, how do you interpret the course of the disease so far? And if you were to make a clinical conclusion at this point, what would that be with regard to what illness does she have?
Yes, sir. She's a 43-year-old female with no prior comorbidities. She had significant nephrotic range proteinuria, sir, associated with edema, therefore nephrotic syndrome. Um, a renal biopsy was done and was started on steroids. Following steroids, which was
Yeah,
gradually.
that's fine. So what do you think, if you were to make a guess, what
Yes,
would
sir.
you guess would she have?
So, according to the history so far, I would keep adult onset nephrotic syndrome as one of the provisional diagnosis.
Yes, I mean, that much is pretty clear that she has a
Yes.
nephrotic syndrome. Do you think is the cause of nephrotic syndrome?
Considering the age, one of the first would be the focal segmental glomerulosclerosis. The second would be membranous nephropathy. Third, sir, since the urine routine also showed RBCs, I would also like to keep IgA nephropathy as one of the differentials.
Right. So why do you keep membranous nephropathy as a possibility here over IgA nephropathy just for the sake of argument?
So, considering just the age and so the rate of the incidence, like membranous nephropathy, I would like to keep it above IgA
But
because
what are
she did not complain of any microscopic hematuria previously or no recurrent hematuria. That would be one of the things.
someone has told her, right, that she has RBCs in the urine?
Yes, on the urine test, sir, but she
Yeah.
no history
Yeah.
of any
So
macroscopic hematuria.
is that a common feature in membranous nephropathy?
No, sir.
Not a common feature. What else is not common in membranous nephropathy? What do you think is her EGFR at this point?
So at this point, sir, her EGFR would be around 40, 45, sir.
So the EGFR is also relatively low,
Yes,
which is also not a common presenting
yes,
feature of membranous nephropathy, right?
yes, sir.
So for these reasons, membranous nephropathy would be less likely, idiopathic membranous nephropathy at least,
Yes,
unless we are saying that there is a secondary membranous where there's lupus as well or something of
yes,
that sort. So one thing you should keep in mind is that perhaps there is some sort of proliferative disease also going on in this case, right? So
yes, sir.
there is a nephrotic syndrome, but in addition to that, there is maybe a proliferative glomerulonephritis, which has led to microscopic hematuria and also a depression of the EGFR as well.
Okay.
The various causes for that are, as you said, FSGS is certainly a possibility, but
Yes,
then
sir.
there could be other possibilities as well. Um, IgA nephropathy, what do you think? What is, in terms of pre-test probability? We all know what the biopsy is going to show, but in terms of pre-test probability, what is the pre-test probability of this case turning out to have IgA nephropathy?
Uh,
Do you understand the concept of pre-test probability?
no, sir.
So pre-test probability, so ultimately, how do you make a diagnosis of IgA nephropathy? How do any of us make a diagnosis of IgA nephropathy?
First is the clinical features.
We do it on kidney biopsy. The diagnosis is
Kidney
made
biopsy,
on
yes,
kidney
kidney
biopsy,
biopsy is
right? So kidney biopsy is the test, right?
yes,
And
sir.
whenever we do any diagnostic test, whether it is kidney biopsy or it is anti-nuclear antibody test or anything, and the likelihood of us getting a positive result or a negative result, it depends a lot on the pre-test probability of that disease being there in that individual, right? So if the pre-test probability is low, then even if you get a positive result, the likelihood that it is a false positive is high. Uh, on the other hand, if the pre-test probability is high, then it is much more likely to be a correct true positive result. So this is something which is important. This is a concept that all of you should keep in mind, and this is valid for all tests, any diagnostic test. You should always interpret a diagnostic test in light of its pre-test probability. Very, very important. So therefore, in terms of pre-test probability, the pre-test probability is not close to zero in this case of IgA nephropathy, but it is low because this patient has presented with a nephrotic range proteinuria, right? So I would not keep IgA nephropathy as a condition high on my list of diagnostic possibilities. So I would keep things like FSGS, proliferative glomerulonephritis, and even Alport syndrome. But in Alport syndrome also you don't expect to see nephrotic syndrome, right?
Yes.
So I think those will even lupus would be a good diagnostic possibility in this case. Although clinically you have said that there is
Yeah,
no.
there were no features.
So I think this is as you are seeing a case, you should start analyzing the case in your own mind. I know that you will do the biopsy. This is not to say that this is a substitute for biopsy, but the whole point of doing this kind of clinical case discussion is for us to be able to judge how do we analytically arrive at a diagnosis. All right,
Okay, sir. Yes, sir.
please carry on.
Yes, sir. During the course of after the steroids were started and then tapered, during this period, the pediledema and the frothiness in the urine decreased. She was asymptomatic and followed up regularly on OPD visits with a stable renal function until 6 weeks back when she had complaints of generalized weakness, increased frothing in urine, and bilateral pedal and generalized weakness. On investigations, the serum creatinine serially increased from 2.1, 2.5, 3.7, and 4.9 over the period of 4 weeks, and the proteinuria also increased. The telmisartan was withheld, and she was started on tablet torsemide.
So, so this illness started 3 years ago, you said, right?
Yes, and 22.
So 3 years ago, and the creatine was 1.4 at that time, EGFR
1.4 at that time, sir. Yes.
40. Do we know what happened to the serum creatinine or EGFR in this interim period?
No, sir. She started following with us when she came in with the creatinine of
I
2.1, sir.
understand, but she must have been getting followed up somewhere
Yes, sir.
because she was getting treatment. She's
Correct.
steroids and then telmisartan and prednisolone also.
Yes,
And
sir.
you said that she was asymptomatic with stable renal function. What does that stable renal function mean?
So her creatinine hadn't, she mentioned that her creatinine hadn't worsened and it was the same, sir. It hadn't increased. This was the word she used.
So what does this mean? The fact that her creatinine has now increased over a 4 week period. What does this mean?
So one of the reasons could be there was no disease progression. And
So what is this? What is this 2.1, 2.5? What is this phenomenon called?
uh, from sir 2.1 onwards, there is a definite disease progression, sir.
So what is happening to her? What would you call this patient in clinical presentation? I think answers are coming thick and fast in the chat. So this is an RPGN-like presentation, right?
Yeah, RPG.
Okay, so this is something uh, which should always almost immediately alert you to the possibility of RPGN, and because you see whatever was the pathology until now seems to have changed at this point.
Yes, sir.
If the clinical course is correct, it all
Yes.
depends because firstly I'm not convinced that the clinical course is correctly described, that her serum creatinine was stable, but maybe it was stable, in which case it has perhaps transformed into an RPGN type presentation. Okay, all right. We'll come back to some of these points. Just let's put a pin in this and carry on.
She was advised a repeat renal biopsy in view of increasing serum creatinine and proteinuria, and was also started on tablet prednisolone 60 milligrams once OD. However, on USG, there was a bilateral small kidneys, hence the renal biopsy was deferred. Presently, she is on prednisolone 60 milligrams OD, torsemide 10 mil.
Matters. Carry on, please.
Yes, sir. Torsemide 10 milligrams OD.
That's
Tablet.
fine. Yeah, you don't have to read out the list.
Okay, sir. I'll move on to the next slide, sir.
Yes, because this is a case discussion. This is not your presentation of a case during ward rounds where you describe what treatment the patient is currently on the list of drugs. Here we want to get from you your analytical skills of how do you analyze a case and arrive at diagnosis and also figure out a plan for this patient, So that is the point. The point is not for me to make a treatment decision at this point. Okay, carry on.
Yes. Past history, there was no prior history of hypertension, diabetes, IHD, cerebrovascular disease, thyroid dysfunction, renal calculi disease, urinary tract infection, or bronchial asthma. Personal history, sleep was adequate, normal appetite, normal bowel bladder habits. She takes mixed diet and no history of any addictions. Obstetric history, she's G1, P1, L1, A0 with full-term normal delivery with no peripartum complications, no history of hyperglycemia or hypertension during pregnancy. And she had a menopause at 43 years of age.
So 43 years is the age at which she started with her illness, right?
Yes, sir, correct.
And so almost immediately she attained a menopause.
Yes, sir.
That's unusual, right? Why should that happen? But once again, let's carry on.
There's no significant family history.
Okay. So again, let's just stop here. So what is, again, we don't know the biopsy diagnosis. She has received some treatment, which might give you some clue as to what the treating nephrologist was managing her for. But what do you think is the diagnosis?
So until now, I think so. It was FSGS would be my first thing, sir. Provisional diagnosis.
And what happened to her recently?
So then, RPGN, sir, rapidly progressive glomerular nephritis. Uh, uh, Probably due to
Sorry?
RPGN would be
RPGN.
yes, sir.
Yeah, I mean, the more recent, but then you yourself have said that the kidney size is small.
Yes, sir. So, sir, it is basically acute kidney injury on CKD, sir.
I mean, look, this is not, how do you define acute kidney injury?
So, increase in serum creatinine by 0.3 milligrams per deciliter in 48 hours, sir.
So this is not that, right?
Yes.
This is happening over a period of a few weeks and it's not coming down, it's
Yes.
consistently going up. So this is, and this is happening on background. Although, AKI can occur, it's not that it cannot occur, but this presentation is more consistent with. So now let's review a patient who has an nephrotic kind of presentation initially and subsequently develops. We don't know yet the investigations, details of the investigations, and later on develops a more RPGN-like presentation, although the small kidneys is odd for this. So
Yes.
keeping this constellation in mind, what are the possibilities?
So the native kidney disease has progressed, leading to the end-stage renal disease.
What is the native kidney disease? That's what we are talking about. This is not a natural or normal progression, right? Happening over a period of 4 weeks, going up from, according to you, I don't know. I have
Yes,
not
sir.
seen the case. You have seen the case, right?
Yes,
So
sir.
according to you, the serum creatinine was normal or stable at least, and then over 4 weeks, it has gone up to 4.5, right?
Yes, sir.
So it is RPGN. It is maybe acute interstitial nephritis on top of it, something like that. So what are the glomerular diseases which can transform into RPGN?
So one is IgA, sir, concentric form of IgA.
Okay, IgA nephropathy can transform at some point into RPGN.
Yes. So then lupus nephritis.
Lupus,
Um, then sir, ANCA-associated vasculitis.
ANCA-associated vasculitis,
Anti-GBM disease, sir.
anti-GBM disease, I
Not
wouldn't
in
say.
this. Yes, sir.
Anti-GBM disease is what is the classical uh, classical thing about anti-GBM disease? It's a one-shot illness. It happens once,
Yes,
right?
sir.
It doesn't
Yes,
go
sir.
on for 3 years and then behave like this. Right. So these are a few possibilities, and then I think some people are presenting other possibilities also in the chat, like membranous nephropathy and renal vein thrombosis, which is very unusual. It's not impossible, but it's extremely unusual to present like this, and that too going on for so many years. In the initial period also, you have given us some histories. If it was that, then this patient should have received anticoagulation, which this patient has not, according to you.
Yes.
So that would tell me that it's unlikely. Then someone says C3GN. That's a good possibility. You should consider C3GN as well. We spoke about MPGN. So any kind of proliferative glomerulonephritis are things to be considered. There are a few things, just a limited number of diagnostic possibilities which can be reasonably excluded, which is pure minimal change disease or a pure classical membranous nephropathy, that sort of thing. Although in secondary membranous nephropathy, you can expect some degree of microscopic injury as well. Membranous nephropathy can transform into percent. So the point here is that keep your mind open. Just because
Yes.
you know the diagnosis, don't get fixated on one condition, right? And then also be aware of the anomalies that you have in your history or clinical findings so far. For example, the rapid rise in creatinine and then the small kidney size, they don't go together, right? Unless something else has happened. So if this is the case, then I would carefully look into the previous records and see whether the creatinine was truly stable or was it increasing, right? So those are the kind of things that you should keep in mind. Okay, carry on.
Sir, on general examination, her BMI was 23.1 kg per meter square. There was bilateral pitting pedal edema.
This is the
Parallel.
examination finding as of now, right?
Yes, sir.
You're not describing the examination findings 3 years ago.
So this is current. Sir.
This is current, during
This is
current.
current, sir. This is
Okay,
current.
yeah, carry on.
She has bilateral pitting pedal edema, no pallor, ictal cyanosis, lymphadenopathy. She's afebrile, pulse is 84 per minute, blood pressure is 140/90 in right arm sitting position. Respiratory rate is 16 breaths per minute. On examination, she has no alopecia, fundus is normal, no malar rash, oral cavity is normal, no nail changes. Systemic examination. On respiratory examination, air entry is bilaterally equal with
Nothing
normal breath
abnormal,
sound.
right? Nothing abnormal in systemic
Nothing
exam.
abnormal, so no,
Okay,
no
please
possible
carry
findings.
on. Yeah.
These are the investigations, sir.
Yeah, okay. Tell me what are the just point
Yes.
out.
So from April 22, her creatinine was 1.4, which gradually increased to sir
There
1.9
you
in
go,
June.
right? So it is not like her creatinine was stable and not going up, as you said earlier.
Yes, sir.
Yeah.
Yes, sir.
So our assumption that this is RPGN was based on entirely your history,
Yes, sir.
which
So
was
this,
not correct.
sorry, sir, I just want to add, sir, this is what she had told me. That is why I presented it that way.
Okay. All right. Okay. Fair enough. She didn't tell you, and this is how you reviewed the records. Fair enough.
Yes,
I
sir.
understand. So now you could perhaps review and say that now on review of the records, it
Yes,
looks
sir.
like
Okay, I'll
this
do.
is not RPGN. Yeah?
Yes, sir.
Okay.
Yes, sir. Her creatinine up till April 2023 was 2.9, which then started to increase
Okay.
from 3.2, 3.9, 4.9, and last follow-up it was 3.7. Her albumin when she started in April 22 was 3, which the latest is 3.2.
Right.
So the urine routine in April 22 showed 3 plus protein urea and 5 to 6 RBCs per high power field, and her 24-hour urinary protein was 7.5 grams. After starting steroids, after around a period of 6 months, her protein urea had decreased to 3.9. 24-hour protein had decreased to 3.5 grams, and then it continued to decrease till September 2024, where it was 1.4 grams. On a last follow-up in May 2025, her USCR is 7,560 milligrams per gram,
So
and her
according to what you've presented here, the hematuria is not remarkable, right?
yes, sir.
Small number of red blood cells, and this is a female. So what is the number of red blood cells which you will consider abnormal?
So more than 3 RBCs per high power field, sir,
Is there
or presence of dysmorphic RBCs.
any difference between males and females?
Sorry, sir, I'm not aware.
Hmm? So I think as a rule of thumb, general principle, I think 3 is fine. But in males, ideally you should not see any RBCs. You know, whereas 3, and in some instances people even go up to 5 as the upper limit, especially in females. So this is important. So this this hematuria is not impressive, I have to say here, at least from the reports that you're presenting. And so mostly it seems to be a nephrotic syndrome, right? Not so much nephrotic presentation. The other points also that you actually, which is conspicuous by your absence, is that you have not described any history of hypertension at any stage in this person, right? Which is something remarkable. I don't know whether it was truly looked for or not. This patient has received telmisartan from time to time,
Yes,
but
sir.
was it given to manage her blood
For
pressure?
anti-proteinuria.
Yeah. So did she have any hypertension at any point or not? I don't know either. But I would be curious, and if I were you, I would try to find that out. All right. So, and there is also a kind of discrepancy between your urine routine examination findings and the UPCR and 24-hour urine protein reports, because repeatedly you see 1 plus. So, okay, let me just now take a pause here and
Yes.
ask you, how do you do urine routine examination?
So we take the first morning clean catch midstream sample, sir, and then we collect it into a sterile open mouth container. Then around 10 ml, 10 to 15 ml, and then we centrifuge it at around 3000 RPM for about 3 to 5 minutes, sir. And then the supernatant is then discarded, and the last drop is then added to a slide and looked under a microscope.
You're describing microscopy, which is different, but I'm
Yes, sir.
talking about urine examination. Let's say
So urine dipstick.
a patient has brought to you a container of urine, right? What do you do? The first thing.
So the urine dipstick, we use the urine dipstick,
What do
sir.
you look for in urine district?
So we can look for proteinuria, glucoseuria.
And before looking at proteinuria, what do you see?
Uh, so the specific gravity and the color, sir.
Color is okay. I think, yeah, color is fine. You should look at the color. But you were saying specific gravity. What is the
Yes.
importance of specific gravity?
So it tells us about the concentration of the urine, sir.
Why do you want to know that?
Sir, because in if it is a diluted sample, so it can show a false negative, false low levels of proteins.
Yeah, exactly. So you're totally right that if the urine is too dilute,
Yes,
then
sir.
I wouldn't even process that urine further,
Yes, sir.
unless this patient has advanced kidney failure.
Yes,
So because that's what some people are saying, it doesn't impact only the proteinuria, but also red cells and everything, right? And
yes,
so if you just go back to the urine reports here, the previous slide, you see that except for the first report where you see 3 plus protein, all the others are 1 plus 1 plus 1 plus.
yes, sir.
So that means that there is some challenge with the urine analysis as well. And so even the hematuria might have been underestimated. Anyway, I mean, all these are speculative, but I think as nephrologists, we should be aware of all these pitfalls.
Yes, sir.
All right. So this is very important. But then, of course, comes the microscopic examination, which you are getting to, which is fine. I don't think. I mean, we used to discuss microscopy, but I don't think any of you have ever done any microscopy. Can people say yes in the chat if they have done any urine microscopy themselves? Truthfully. There are quite a few yeses, and I suspect some of those are well. Who am I to say? But I don't think that many people who are saying yes have actually done urine analysis themselves. Because, yeah, I wish there was time and I could interrogate some of these people who are saying yes. How did they do it? But we'll take it on face value. Some of you might be more than 50 years old, in which case it is possible. All right, carry on, Dr. Mehta.
Yes, sir. So, the serological investigations are normal, sir. ANN negative, ANCA was negative, C3, C4 was normal.
What else will you test in such a situation?
Sorry, sir.
What other tests will you do?
So, to rule out membranous, I would also like to do a plateau, sir. Anti-plateau.
Why are we talking about membranous? I don't think membranous is very high on our list of possibilities. You can do PLAT.
Also, screen for HIV, hepatitis B, hepatitis C.
I think those are the conditions which are associated with sometimes proliferative glomerulonephritis. What else? Please always do serum electrophoresis in all cases. All cases where you suspect glomerular disease should do serum electrophoresis.
Okay.
Because monoclonal gammopathy is an important cause of a number of morphological presentations of glomerular diseases which we overlook. So you must always look for evidence of any sort of plasma cell dyscrasia or monoclonal gammopathy. All right. So these are essential list of tests, and there could be others depending on the context.
Okay.
Okay, carry on. So these tests were done during the current admission, not
During the current admission. Yes, sir. During the current admission.
Okay, please carry on.
So just a minute, sir.
Someone says Benz-Jones protein. Why do you want to look for Benz-Jones protein? So just to clarify, look, I think Benz-Jones protein, we understand it is this test is done for a diagnosis of light chain proteinuria, and light chain proteinuria is typically a feature of myeloma cast nephropathy, if anything. So if you are suspecting myeloma cast nephropathy, then for sure look for it. But in this case, the possibility of this presentation being due to myeloma class nephropathy is extremely, extremely low. Even if there is kidney disease due to monoclonal gammopathy, it is a glomerular disease likely, in which case you won't get a Bence-Jones protein positive in the urine. So, so that wouldn't be, again, it goes to the point of doing a of the pre-test probability. So the pre-test probability of Bence-Jones proteins being positive is extremely, extremely low. So even if it is positive, I would take it with a pinch of salt because it is likely to be an analytical error or something of that sort. All right, please carry on.
Sir, I'm having an issue with the PPT. Just 1 second, sir.
Jugal, any problem? You can continue.
Sir, I'm not able to change the slide, sir.
Why don't you stop sharing and start sharing again?
Stop sharing and share again.
Okay.
Yeah.
So this is a comparison of the USG which was done in 2022, which showed a normal sized kidney and normal echo. And the present USG shows the right kidney of 8.4 by 3.2 with raised echogenicity, as well as the left of 8.2 by 3.5 centimeters with raised echo.
Yeah, now it makes sense given the fact that she has been progressively losing kidney function
Yes, sir.
the last 2-3 years. All right, please carry on. Carry on, please.
Yes, sir.
Vineet, you are on mute.
Jugal, you can speak out. If you don't want to, can't just speak out.
So I'll just do that again. The biopsy which was done in 2022 showed a total of 7 glomeruli, 3 out of which were shrunken and sclerotic. The glomerular shows mild mesangial hypercellularity and a mild increase in the mesangial matrix. There is no endocapillary hypercellularity. The glomerular walls were normal. At light microscopy, there was no crescents, no necrosis, no definite segmental sclerotic lesions. The tubule showed a mild patchy interstitial fibrosis and tubular atrophy of approximately 10%, with mild interstitial lymphocytic infiltrates. The remaining tubules showed a mild swelling of the epithelial lining, and a few of the tubules showed hyaline cast. The blood vessel did show the small arteries and arterioles showed moderate medial hypertrophy, and the IF findings showed 3 plus IgA staining and C3, and the Oxford MEST C score was M1, E0, S0, T0, and C0.
Okay. So
Okay.
what? Okay, tell me what do you make of this report?
So based on this renal biopsy, the diagnosis would be IgA, sir, because of the IF showing the dominance of IgA staining.
Okay, what else?
So the arteries.
Even a
Sorry.
gynecologist will tell you this is IgA nephropathy. But as a nephrologist, what do you want to tell me?
Since the 3 glomeruli were already sclerosed, it showed the decreased renal dysfunction at that time as well. And the arteries also showed the arterial.
Exactly. So that's an important point. So let's pause there. So 3 glomeruli are sclerotic. What does this mean? Is it
Sir,
disease?
first,
Is it due to IgA nephropathy?
So possibly.
Possibly. Okay. All right. I wish this was a live session so that we could ask others also. So look, I think if you have read your MIST classification or biopsy interpretation of IgA nephropathy, there is there is relatively little value placed on global glomerular sclerosis, right? Because global glomerular sclerosis can be present for other reasons also. It is not necessarily linked to IgA nephropathy. That is why here, if that is the case, why is it S0 here? What is S0?
Zero shows the segmental sclerosis, sir.
Exactly. So segmental sclerosis is the lesion that has linkage with IgA deposit or IgA nephropathy. Okay, so that's important. So I wouldn't place too much value on the fact that you see three globally sclerosed glomeruli and immediately interpret that these are sclerosed due to IgA nephropathy, so the disease is progressing. All right, people can have global glomerular sclerosis and can be fairly stable. So that's number one. The only thing that you see is that there is some degree of mesangial hypercellularity, and that too is 10%, right? So it's mild mesangial hypercellularity. There is no endocapillary hypercellularity. What does that mean?
So no active proliferation.
There is no active inflammation going on.
Yes.
All right. So there is no active inflammation going on. And at that stage, at least there was no tubular atrophy as well. Okay.
Yes.
So, so these are important features, of IgA nephropathy. But what is like Sherlock Holmes, the dog that did not bark, which is missing in this biopsy report, the entire biopsy report?
Missing part, sir.
Sorry?
The missing part.
Yeah. What is not fully explained by this biopsy necessarily? I think someone has actually given the correct answer. Dr. Tarun Pahuja says electron microscopy.
So the EM wasn't there.
Yeah. Why? Why do you want to see the EM?
To see whether there was the food process effacement of.
Right. So this is 7 grams of proteinuria, right?
Yes.
And in 7 grams of proteinuria, you don't expect it to be there just simply because of IgA nephropathy. And in all cases, it is well known that some patients of IgA nephropathy can have coexisting minimal change diseases.
Yes.
Right. So in minimal change disease, the only way you can confirm the diagnosis is by doing an electron microscopy and showing what?
Diffuse food process effacement, sir.
Diffuse food process effacement. The word diffuse is very important. There can be some food process effacement in any proteinuria kidney disease, but if it is diffuse food process effacement, then it indicates podocytopathy, right?
Yes.
And so podocytopathy. So always do, in anyone who presents to you with this degree of proteinuria, always send for electron microscopy. Very, very important as someone. So don't think that electron microscopy costs 5,000 or 6,000 rupees more. So we should save that patient the money, right? So that's important. Okay.
Yeah.
All right. So now you tell me what is. So this was the histology at that time. It doesn't look really very alarming, right? But still, this patient has now progressed to advanced kidney failure. Kidneys have shrunken. The GFR has been dropping relatively rapidly over 3 years or 3 years.
Yes.
She has now
3 years.
gone to an eGFR of close to 50, not 20, right? Or
yes.
What does that tell you?
There is increased chronicity, sir, and
of course there is where is the chronicity? Chronicity wasn't there at the time
at the time that was 3 years. Yes.
Right. So there has been the disease has progressed rapidly, relentlessly. So it tells you, but What do we know about the natural history of IgA nephropathy?
The around 20 to 25% of the patients will land up into end-stage renal disease over a period of 15 to 20 years, whereas the around 80% has good survival rates over 10 years. It is slow progresses.
Yeah. Well, I mean, that's it is progressive, but it is the risk of progression was considered to be relatively low, right, in the past. But now we have data from the UK radar registry, which has shown that in adults, 50% of individuals who have proteinuria of more than 0.5 grams progress to end-stage kidney failure in 10 years. 50% in 10 years. So that's a very high rate of progression compared to what it was earlier. Someone had actually pointed out something else also, which I would have wanted to discuss more, but there wasn't time, about C3 staining. So you have written here 3 plus IgA and C3.
Yes, sir.
Is C3 also 3 plus?
No, sir. C3 was a 3 plus.
So what was the C3, the intensity of C3 staining?
Sir, they hadn't mentioned it on the original report.
They would, right? And also you haven't actually, I should have asked you that question. What about IgG? What about IgM? Right? So because if immunofluorescence was done, what is the standard immunofluorescence panel?
So it consists of IgG, IgA, IgM, C1q, C3.
So they don't do C1q routinely, but again, as Dr. Nikita Agrawal says, the light chain staining. Light chain staining, many people don't do, but it should be done. Light chain should be part of standard immunofluorescence panel. So that's something very important. And so I don't know what you mean by C3 here, but if C3 is actually also intense, 2 plus or 3 plus, then it is interesting. This is an interesting finding, which we can discuss later because it might have treatment implications on how do you treat these individuals. Because the role for complement has come up very, very strongly over the last few years in the pathogenesis of IgA nephropathy, and it has become now an important treatment target. Okay, but that's something which we don't have time to discuss. But Dr. Anirban, thank you for actually pointing out the C3 bit here. All right, so now just coming back to radar. So why is this important? This is important because this has now implication on how we manage people with IgA nephropathy. So until recently, the consensus was that people with IgA nephropathy, really, you don't need to worry about them until they have a lot of proteinuria. But now, because we know that people with even half a gram of proteinuria, half of them will progress to end stage in 10 years. In children, it is 1/4. In adults, it's half. So that means that all these people will require treatment. All right. So the treatment threshold has been lowered now. Okay. Okay. So now let's transition. What would you do next? Let's say we go back 3 years. And this is the patient who came to you. At that time, the serum creatinine is 1.4. This is the biopsy you've done. What you would have done at this point? You made a diagnosis of IgA nephropathy. The MEST is M1, E0, S0, T0, C0, as you have it here. What are your next steps?
I would start with the supportive treatment, antiproteinuric, this thing like lifestyle changes, the blood pressure control, antiproteinuric by ACE-ARBs. Then also for this thing, I would the budesonide, look.
So you are immediately jumping to treatment, but before that, So one is that the first thing to do is to rule out secondary causes. All
Yes,
right.
okay. Yes, okay.
Anyone with IgA nephropathy diagnosis, what are the secondary causes? Very quickly.
So it can be CLDs, then ulcerative IBDs like ulcerative colitis, Crohn's, or then autoimmune diseases like SLE, rheumatoid, then herpetitis dermatiformis.
SLA is not a common cause of IgA nephropathy, but yes, IBD, cirrhosis, even post-infectious. Sometimes you can have IgA dominant post-infectious GM.
Yes,
So you should
by
keep that
stash.
in mind. All right. Other hepatitis B infection, C infection, all of those can cause IgA nephropathy. So and then the second thing you should look for is evidence of IgA vasculitis, especially if it is a child. All right. Third is something that you should always do, which has been done here, is to calculate the MEST score. And then what is the fourth thing you will do? On how do you decide what is likely to happen to this patient over the next 5 years, 10 years?
So there is an IgA risk prediction tool.
Yeah, so there is an international
Yeah,
IgA nephropathy prediction tool. So that is the next thing you should do, right? Because that will help you prognosticate. It only
yes, yes.
helps you prognosticate. It doesn't help you make treatment decisions. Very important. Important to remember that it's not for treatment decision. All right. But the fact is now that we know from radar that anyone with a half a gram of proteinuria is at risk of progression. All of these individuals need treatment. Okay. Uh, so then you said budesonide. What do you mean? Do you want to expand on budesonide? What is the purpose of giving budesonide?
Basically, decreases the local production of the IgA1 antibody, immunoglobulins, which are produced from the Peyer's patch.
IgG1?
Sorry, IgA1, sir. Galactose deficient IgA1.
Right. So abnormal IgA1, abnormal IgA, which are produced in Peyer's patches, which are galactose deficient. So you want to, you want to use. So what kind of budesonide helps you do that?
Sorry, sir. Sorry, sir, I didn't get the question, sir.
Yeah. This is something you should know, just don't say budesonide. Again,
No,
that's a
sir.
gynecologist type answer. What kind of budesonide you want?
Targeted release, sir.
What is targeted release?
It releases at the small colon, sir. At the side of the Peyer's patch.
Sorry?
At the Peyer's patch, at the small intestine, sir.
Where in the small intestine?
Ileum, sir.
Ileum, distal small intestine. And how
Yes.
does that release happen? How does it know that it is in the ileum? No, it senses the local pH. So it's a targeted release formulation. So when it comes in contact with fluids, intestinal fluids of a particular pH, then the budesonide is released exactly in the area where in the distal ileum you have the Peyer's patches. This is important to know because in India people are using budesonide left, right, and center, and that is not this type of budesonide. All right. So you are, I wouldn't say exactly fooling yourself, but you are not doing what you said you are doing, right? You are saying that you're using target release budesonide, but you're not doing that. So the budesonide or antiquad that is used, that is available in India, where is this one released? It is released in proximal small intestine and it is released in the colon, right? So this is important. This is not released in distal small intestine, right? So it is not my case to say that it will not work, but we don't know. This is not the same formulation, all right? If we think that we are giving our patients this particular agent and we are actually helping reduction in the GD-IgA production, then that is not correct, or that is a misconception in our own minds. This is very important. I'm spending some time over it because then we'll just come to that point is the goal of treating anyone with IgA nephropathy. What are the goals? What are the big goals of treating someone with IgA nephropathy? What is the single most important goal?
Decreasing the proteinuria, ideally keeping it less than 1 gram.
Is that the goal? I mean, is that the long-term goal?
And so, preventing the renal dysfunction,
Yeah.
declining GF.
Management of a long-term management of all progressive kidney diseases, the goal is to slow progression or stop progression. So
Yes.
in IgA nephropathy, because now clinical trials are showing that it is possible to slow down the progression of the disease to less than 1 mil per minute per meter squared per year.
Yes. Yes.
Reduction. So that is the goal of treatment. All right, that's the long-term goal. But then in long-term goal, you will not know right away. It will take you some years to find out whether you are achieving there or not. So the surrogate goal or intermediate outcome is proteinuria. And this is something which has been shown that there is a very strong correlation between proteinuria reduction and long-term EGFR preservation. Right?
Yes, sir.
So therefore, in the short term, we are following the proteinuria. And what is the target with regard to proteinuria?
So ideally less than 0.7 grams, sir.
0.5 grams,
Yes,
or
0.5.
even better, 0.3 grams per day. All right. So this is your goal in the short to intermediate term, and long term is to stabilize the EGFR. Okay. So that is your clinical endpoint. Now, how do you achieve that? If now you transfer that, and we are going to skip over that about the pathogenesis of IgA nephropathy because that's a theory question. We are not doing a theory discussion here too much. But keeping, I'm assuming that you have an understanding of the pathogenesis.
Yes, the
What
four
is
hits.
what is the pathogenetic, in terms of the of manipulation of the pathogenic pathways? What is the goal?
The first is the first would be to prevent the galactose deficient IgA production. The
Okay,
second would be to prevent the immune complex formation.
how do you prevent the immune complex formation?
The first, sorry, after it gets deposited, the complement the activation, which causes the glomerular.
So maybe, I don't think that any of us can be that specific. So as you correctly said, the first goal is there are three main goals of treatment of IgA nephropathy in terms of pathogenesis. The first one is to act at the site at the root cause, which is GDIgA production. That we try to decrease the GDIgA production, and the only intervention for that is with Nefecon or target release budesonide, right? Then the second is that let's say if there is GDIgA is produced, then the GDIgA will lead to development of antibodies against the GDIgA, and these antigen antibodies now they will combine and they will get deposited in the glomeruli and they will produce inflammation. And that is why we talked about inflammation. So the second is to prevent this inflammation and injury that will happen as a result of inflammation in the all right. So that is the second goal. And the third goal is to manage the consequence of inflammation, IgA nephropathy, IgA production, etc., which will lead to nephron loss. This inflammation will lead to nephron loss. So then the nephron loss, we all know that if nephrons are lost, you will have hyperfiltration in the remaining nephrons and so on and so forth. So you need to manage that bit. So that is non-immunological, right? So there are two points at which we can intervene in the immunological pathway, and one is non-immunological. Right? So as we said, we use budesonide to decrease the GDIgA. What do we use to reduce inflammation?
Steroids.
Yeah. So systemic corticosteroids. at this point, right? Systemic corticosteroids are the only is the only thing which we target for minimizing inflammation. And then for managing consequences of nephron loss, there is this whole list of interventions which you described earlier: lifestyle interventions, BP management, use of ACE inhibitors, SGLT2 inhibitors, and now we also have, what is the new addition to this list?
To the lifestyle also
Yeah,
to the
yeah, yeah. To the how do we, so for managing the nephron loss, consequences of nephron loss, we have had the ACE inhibitors, the SGLT2 inhibitors that they have been shown
yes,
to be effective through clinical trials. One more agent.
we have this dual endothelin and
Yeah,
angiotensin receptor blockers, sparsentan.
endothelin angiotensin receptor antagonist or sparsentan.
Sparsentan, sir.
Yeah, so sparsentan. So this is the only, these are the four or the three classes of agents which we use
Yes,
in
sir.
this. Sparsentan is not available here, so we are not able to use that for this well. All right. So this is important. So let's say now let's just come back to the GD-IgA production. So the so Nefecon, all right. So what is the evidence on the basis of which Nefecon is prescribed?
So there was a Nefigard and the Nefigard trial, sir.
Yeah.
Yes, sir. Yes.
So in Nefigard trial, how long was the Nefecon use?
The Nefigard used budesonide for some 9 months.
9 months. Okay.
9
So
months.
this is important. So it used budesonide for 9 months. It showed that proteinuria came down, and even EGFR rate of
The
for
rate of decline.
used. All right. But we all now understand, because this is why it is important to understand the pathogenesis, that 9 months is not going to lead to reduction in GDA, IgA for the rest of this person's life. Right? So most likely these people will need repeated courses of
Yes.
target release budesonide. So this is very important, right? So don't think that we've given them for 9 months and then your job is done. Okay. So these patients will need to continued follow-up. Now, and then I think someone mentioned a bit earlier. So there are a few other things which have been tried, especially in the Chinese population, which is HCQS,
MMF has been tried, sir.
MMF, HCQS, but only in Chinese population. They haven't worked in non-Chinese yet. All right.
Yes, sir.
So something for us to just be mindful of. We already talked about podocytopathy in IgA nephropathy. How do you manage podocytopathy?
The initial one would be, sir, giving steroids.
How?
Pulse steroids can be given, or steroids at 1 milligram per kg per day
Yeah,
for 6.
I don't know, but you simply manage them like minimal change disease, right?
Yeah, like MCD, yes, sir. Like
There is
MCD.
yeah, minimal change disease.
Yes.
So that's the one bit. Now, in this patient, let's just come back to this patient. And this patient, now we know that the clinical picture was different from how it was presented. But let's say if you have a patient with IgA nephropathy who suddenly presents with a decline in EGFR, right? What are the possibilities?
So one of would be a crescentic transformation, sir.
Yes.
Yes, sir.
What?
Sorry. So one would be crescentic transformation. The second would be, sir, the hematuria causing cast and then causing an increase in the creatinine.
Yeah, so hematuria has been gross hematuria. It's very
Gross
important.
hematuria, sir. Gross hematuria.
Episodes of gross hematuria have been associated with the development of acute kidney injury. And in this, it's not cast, because you don't get cast because of hematuria in this situation. But it's that just the gross hematuria leads to tubular injury. And so the tubular injury will cause acute deterioration of kidney function, and that takes some time to recover. So you should wait for a couple of weeks after any episode of acute hematuria. if there is a decline in kidney function, right? And if that doesn't get better, then you should do a kidney biopsy. But you should also consider maybe superimposition of other conditions like ANCA-associated vasculitis, even anti-GBM disease getting superimposed over IgA nephropathy has been described. So be mindful of that and do a kidney biopsy a little bit earlier.
Okay.
Right. Now, let's say you have a patient who has features of vasculitis, skin rash. Someone does a skin biopsy, shows IgA nephropathy, and most likely these will be children. And so the child's father or parents, they come to you and say, what are the risks? And you explain to them one of the risks is that the kidneys may get affected with IgA nephropathy, right? So they ask you, what can we do to prevent that? So how will you counsel that parent? So someone is advising tonsillectomy in Japanese, but we are not in Japan. So let's talk about our patients.
So regarding the risk of
Question is, this is something which has been which used to be very common in the past. Someone comes to you with skin rash, someone comes to you with abdominal pain. Do you give them prophylactic steroids? Is there a role for steroids in such a situation?
So we'll have to look at the proteinuria and the active sediments, sir.
Yeah, if there is proteinuria, if there is active sediment, then it is not prophylactic anymore. Then you likely are dealing with active disease of some sort.
Yes, sir.
But I think
So then observation is observation and repeat frequent monitoring, sir.
yeah, the answers are consistent and unanimous in the chat that no, there is no role for prophylactic steroids in such a situation. So that's important to remember. Okay. All right, we are coming towards the end. So just tell me, and this is a theory question, so maybe not so relevant for clinical examination, but it's important to know because IgA nephropathy right now is the most active field in clinical trial world. There are so many drugs under development that every month a new drug is, or every year certainly a couple of new drugs are getting approval. So because this is also the field of IgA nephropathy has helped design of clinical trials in glomerular disease. So can anyone tell me what changes have been introduced as a result of IgA nephropathy in clinical trial design?
In the trials, sir.
Clinical trial design, how we design clinical trials. I know that you guys are not interested in clinical trials, you guys are not interested in research, but I hope some of you will be. I think someone says here that they've started targeting proteinuria as outcome, and you are right. So, in US there is an initiative called the Kidney Health Initiative. So, Kidney Health Initiative some years ago conducted a meta-analysis of clinical trials, and they found that reduction in proteinuria was strongly predictive of stabilization or stabilization of EGFR and preservation of kidney function. So now the US FDA, it accepts proteinuria as a surrogate endpoint for considering approving a drug or putting it on rapid approval pathway. So now the way clinical trials are designed is that a clinical trial starts, and then at the end of 9 months, we are supposed to see what happens to the proteinuria. All right. So if there is a significant signal in proteinuria, typically a 40% decrease in proteinuria, then FDA will likely give this a rapid accelerated approval. And then at the end of 2 years, you look at EGFR slope, right? So this is the clinical trial design. So what this has meant is that now you can significantly shorten the duration of clinical trials. And the process of drug development has become easier. And so that's the reason new drugs are now coming into the market relatively fast. In the past, it used to take 5 years, even longer, for any such clinical trial to be completed. Right? So this is something which is very, very important. And again, can you or someone else simply tell me the broad class of drugs which are currently under investigation for IgA nephropathy?
So there is BAF inhibitors, then there is April and BAF together. Then
What BAF and April do?
yes, sir. BAF basically decreases the B cell activation, sir. Whereas the April is also involved in B cell stimulation.
Yeah, so both act on B cell activation or stimulation, right?
Yes, sir.
So they
Yes,
are
sir.
B cell targeted therapies.
Yes, sir.
B cell, BAF, April. What else? What other classes of drugs?
So there is factor B inhibitors which target the complement.
Yeah, so in complement, both the lectin pathway and the alternate pathway of complement is thought to be involved. And so drugs that target both of these pathways are currently in clinical trial. And then there are drugs which target the final common pathway also of complement. So terminal complement, and then finally even plasma cell targeted drugs are in clinical. So they're exciting time for IgA nephropathy, but we have to be mindful that these drugs are likely to be away from the Indian market for a very long period of time. And even when they become available, they'll be extremely, extremely expensive. So we will have to still continue to rely on the tried and tested agents, which are the ones that we discussed a little bit earlier. Even targeted release budesonide is not available. And again, someone did put a little bit earlier in the chat that Dr. Susina Alexander from CMC Vellore is planning is planning a platform trial. And so in that platform trial, she's going to evaluate a number of therapies on the same platform. We don't have time to discuss what the platform trial is. That's also a very, very interesting thing to discuss. If some of you are interested, I would encourage you to go ahead and read about platform trials. Because they are a new way of efficiently testing multiple agents and reduce it. Because earlier we are used to doing just top 2-arm trials. We have one arm in which we have the investigational agent, and in the other arm we have the placebo, or we have the standard of care. But now we have now these platform trials, and these platform trials give us the design to test multiple agents at the same time. And the way these agents are tested is that that you can test them. And if you see during the period of a trial that one drug is not working, you can take it off the platform. You can bring another drug into the platform. So it's very versatile. I think those type of and yeah, you're right. These are called adaptive trials. There are many other components of adaptive trial. This is one of them, platform trials. So I think I'll stop here, and we have another 10 minutes or so. So very happy to take any questions if you have, any of you.
Thank you, sir. This was a very clinically insightful bedside. There are 2 or 3 questions in the chat box that we will like to take. The first one was, in this case, when the student tells the clinical diagnosis at the end of history, so what is most appropriate to be told? Like a case of nephrotic with AKD or a case of RPRF? This is always a dilemma in our bedsides. So what should be told, sir?
Yeah, look, neither nephrotic nor AKD is a diagnosis. It's a classification, it's a system of classification. So it's in a way you're afraid of making a diagnosis. So you say nephrotic syndrome, you say CKD, you say AKD. If possible, try to arrive at a cause, discuss the cause, right? So many of these people will have you can say AKD. It is simply a descriptive term that just because you don't know when the creatinine went up, you call it AKT, right? Or that if you know that the creatinine was high and has stayed high for 2 weeks, 3 weeks, 4 weeks, you call it AKT. So that's fine. That's all right. Either way is fine. Nephrotic. And clinically, how did the patient present first? The way you presented this case, you said the patient started with edema, right? So the
Yes,
presentation was clearly nephrotic presentation. You don't
yes,
see
sir.
that in any kind of acute kidney injury or anything. So I think these are syndromes, and syndromes are clinical syndromes. Syndromes are not based on biopsies. Syndromes are not based on investigations. These are clinical syndromes. So the clinical syndrome, I would say, is a nephrotic syndrome. AKD is something you find out only from investigation. And similarly, please never just say, what is the diagnosis? The diagnosis is CKD. I hate it because CKD is not a diagnosis. That means you don't know nephrology. If you just say that the patient has CKD. What is this? What CKD is simply a classification scheme, right? If the creatinine has been up and has been up for 3 months, you say CKD, right? What does that mean? It doesn't mean anything. It's just a starting point. It's just a starting point.
Okay, sir. So, Dr. Ambar wants to ask if IgA with concomitant C3, as was in our index case, is suggestive of local complement activation, and is the course of like IgA with concomitant C3 different from IgA without C3
Yeah, so
clinically?
that's a good question. Actually, there is evidence to suggest that IgA with C3 is worse in terms of its prognosis. It's more active disease and more aggressive disease. So yes, is the short answer to that.
And sir, at what level of chronicity, like at above what IFTA, you will decide not to treat a case of IgA? Say if the IFTA is 35 to 40%, will you still treat IgA?
I would still treat IgA. I think the diagnosis, so I would treat IgA until the eGFR is less than 30, because all of these individuals who have been enrolled in these clinical trials, we have used only clinical criteria. So please, again, let me come back. Neither MEST score nor any other histological abnormality is predictive of treatment response. So the treatment response has, in the clinical trials, been made purely on the basis of clinical grounds, the proteinuria, the eGFR values. And that's what I would go by until we have new evidence. And if the new evidence says that, yes, certain specific findings are indicative of the likelihood of good response or not. That is why this, as I said, this field is very active. And maybe there will be a combination of biomarkers. Many of these clinical trials, they have stored biological samples, and so there will be very busy biomarker community in the next few years trying to look at the biomarkers which will predict response.
Sir, how are we correct in applying MEST-C scoring in this sort of inadequate biopsy? Like MEST scoring should be applied when the biopsy is adequate, say 8 or 10 glomeruli are there. In this index case also, it was a sort of an inadequate biopsy. So are we correct to apply
Yeah,
MEST scoring, or
no, you are right. So we have to, the first thing in any biopsy is to establish adequacy. If the biopsy sample is not adequate, then obviously all bets are off in terms of, but again, this is here, we see the MES score. The MES score doesn't help you in deciding treatment. It simply helps you in just getting at the state of activity with that. So I would say in any case, the utility of MES scoring is very limited. The other thing which we did not discuss is the behavior of IgA nephropathy in different populations around the world. So there is quite good evidence to suggest that IgA nephropathy in Indians or in Asian populations behaves differently compared to Caucasian populations. So the IgA nephropathy in Indians is much more sclerotic and perhaps proceeds or rather progresses more rapidly, as you saw in this case, right? That over a period of 3 to 4 years, this patient progressed to eGFR of less than 20, right? So that's really very important. What it means that perhaps either we are missing in diagnosing these cases earlier, or that yes, possibly something else is different pathogenetically, which we need to study more, right? So that's something for all of you guys, because you are the upcoming researchers. So for you to find out what is special about the Indian population. Maybe the genetics is different, maybe the pathogenesis, something else is there, some infection is maybe modulating the course of this. So could be a number of things, or could be some environmental factor and so on.
Dr. Vineet, sir, any other questions are there?
So look, a few things I'll just want to make a point is that someone here is trying to, so we try to overinterpret, someone is saying steroid and CNI is better to act on podocytes. Look, do not use that kind of argument to justify a particular agent. That is why we have clinical trials, and that's the point of doing clinical trials. Clinical trials tell you what is an effective therapy, because otherwise you can treat people with all kinds of random agents just because you think it is justified. Just because there is proteinuria, you should use CNIs, etc. I don't think that those are the kind of approaches we should be making on our own judgment. I think the only kinds of treatments which we should be using are treatments that are broadly proven through clinical trials, or treatments that the broader nephrology community or the broader community has consensus on. That's very important.
Dr. Shimna is asking that how long you give systemic steroids and MMF?
So steroids, I would continue, again, go by clinical trials. So I would continue steroids for as long as used in the low dose testing trial, which is 6 to 9 months. All right. But please do be mindful that even in testing, the proteinuria tended to come back. As I said a little earlier, these are not treatment approaches that hit at the root of the pathogenesis. All right. So these are only temporizing, and people will likely need more than one course of the disease. And some other questions are being asked. And again, will you give steroids if it is E1 but significant IFTA? Let me re-emphasize, it is not based on IFTA, or it is not based on the presence of E1 or E0 lesion. It is based on clinical criteria. What is the proteinuria? What is the EGFR? That's it. Whatever is the, of course, if there is endothelial injury or endothelial inflammation, that means that there is active inflammation going on. And you might want to actually give steroids, but the primary indication would be based on the parameters that were used to include people in clinical trials. Role of HCQS, yes, if there is someone who's resistant, you can use HCQS. So the HCQS, mycophenolate mofetil, etc. If you've given steroids for 3 months or so, the patient is still having proteinuria or showing decline in EGFR, there is no other cause, please feel free in using HCQS or MMF as a rescue therapies. How long oral targeted glucosinide? Again, 9 months. This is the. I come back to clinical trial evidence. The clinical trial evidence. Don't use or make up your own duration, right? So give it for the duration for which it was given in clinical trials. Because otherwise, if all of us become individual experts, then it is free for all, right? Then all of us, I say Dr. Vineet Bera doesn't know how to treat. I only know how to treat. And then Jasmine Sethi says Dr. Jha doesn't know. I would give it for whatever period of time. But clinical trials have been done by experts. They have been done by a steering committee which arrived at consensus. So question, IgA nephropathy prediction tool, KFRE validated in Indians? The answer is no. They have not been validated. We need these studies. And I know that some of these studies are currently ongoing. How do we explain the creatinine on 1.4 based on this biopsy? One point that was made by Dr. Bera, you said this, right? That this could be inadequate. We don't know whether this is fully representative of whatever is happening in this kidney or not. And there could be other things also that is going on which are not sampled. We all know that kidney biopsy is a kidney biopsy, still needle biopsy. What do we say as the list of DD? Maybe this person was sleeping because we discussed the DD quite extensively. And
Sir, I think the questions are pouring in because we are all fortunate to have you here. And you being the authority in IgA nephropathy, they are all giving up questions. But I would just like to reiterate what Sir told, that understand the pathogenesis of IgA nephropathy and target all those points. And based on the clinical presentation of the patient, and the duration and the lines of management should be based on trials. So that, if I may summarize, and Sir would agree, should be our take-home message. And and I would ask Dr. Jasmine to please conclude the session. And thanks, sir.
Thank you, Jha sir. And I would also like to thank all our attendees who have very actively participated in this case discussion. Thank you, sir, for taking out your precious time for taking our bedside. We thank you all and will like to conclude this session. Thank you, Vineet sir. Thank you all.
thank you, Jasmine. Thank you,
Thank
Vineet,
you,
and
sir.
thanks everybody. Thank you, Jugal,
you,
for
sir.
presenting this case. You've done a fantastic job, and you discussed the case well as well. And
Thank you so
again,
much,
let me
sir.
say that I'm very happy to come back again if you want. So because I enjoy the interaction with young minds. As I get older, I need more interaction with younger people. So it's fantastic, and I'm very pleased to see so many people join. So good, well done.
Thanks, sir.
Thank you
Thank
and
you,
good
sir.
night.
All right, bye bye.
Bye.